Hello, this is Antonio Esgueva. I'm a breast surgeon from Clínica Universidad de Navarra in Madrid, Spain. The idea of talking here with you is about the results of our latest study, which is about the use of the intraoperative ultrasound for DCIS, which is a ductal carcinoma in situ of the breast. Ductal carcinoma in situ of the breast is that pre-malignant lesion that if left untreated most of the times, or have a high risk of it developing as a breast cancer. So at the moment, most of the surgeons will perform a surgery. I know there are several studies running right now about not doing any type of surgery, but anyway, we're going to center out the surgical part of it. The problem with DCIS is that mostly it presents as microcalcifications on the mammogram, and most of these microcalcifications are not seen under ultrasound. So we can't perform an ultrasound if we don't know what to excise. The good news is that there are ultrasound visible clips that we can place it at the area of the calcifications, and that way it can help us like in the guidance of the surgery. We see the clip, and then with the mammogram we can create our pattern, we can create what we want to excise, and that's the idea of the study. Because for breast cancer, for non-palpable breast cancer, we've used it either by seeing the cancer itself under ultrasound or by placing a clip, and we have really good results. Not only similar results to the wire, but it has even better volumes, even less positive margins, and patients are happier because they avoid the wire. Then we've developed this study, which was to compare the patients that underwent surgery with ultrasound, intraoperative ultrasound, and the patients who underwent surgery with the wire. The wire is really uncomfortable because it's placed that the day of the surgery in the radiology department. It's a needle. You have to place it. You have to check it's in the place. Then if it's not, you have to move it, and it's really uncomfortable for the patients. With the ultrasound, the moment we perform the biopsy, we place the clip that we can see it, and that's all. The patient goes directly to the OR without the need of going through the radiology department. For that, we have included 108 patients. 41 of them had the intraoperative ultrasound, 67 had the wire localization. And then we wanted to check is the surgical volume and the rate of positive margin, because if we get a positive margin, that means that we have ductal carcinoma in situ cells on the surface of our specimen that needs a second surgery in order to make sure that we don't leave any residual DCIS in the breast. So that was the idea of the study. And I think we're quite happy with the results, because we've seen that in the intraoperative group, we have less than 5% of positive margins, while in the wire group, we have more than 10% of positive margins. And that means less than 5% of second surgeries in the intraoperative group and more than 10% of second surgeries in the wire group, which is something interesting. Then about surgical volumes, which is something that we wanted to see. In the intraoperative groups, the volumes tended to be smaller compared to the wire group. And not only this, we have checked with the calculated resection rate, which is a mathematical formula that permits us to evaluate the excess of healthy breast tissue that resected. This is a bit tricky to understand, but in an ideal world, we would excise the DCIS with just a couple of 1 or 2 millimeters of healthy tissue around. This is in an ideal world. In the real life, it's almost impossible to perform that type of surgery. So we always excise a bit more of healthy breast tissue than the ideal minimum. Then if we compare our two techniques, we find that in the ultrasound group, in the intraoperative ultrasound group, we excise half of the healthy breast tissue compared with the wire group. And that we hope it may have an impact on cosmesis and also for patient satisfaction. And I think those are the main results of this study. It's much more comfortable, less amount of less rates of positive margins, less second surgeries, and less healthy breast tissue resected compared to the wire. It's for DCIS, for intraductal carcinoma in situ. The idea is to get rid of the wire. As we were saying before, it's really uncomfortable for the patient. You know, you have a surgery that very day before the surgery, you need to go to the radiologist. Then he will get a needle, a long needle. He will put it in your breast. He made me moving it, and it's really, 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 really stressing. It creates a lot of anxiety, and even the wire can move. That way, the surgeon won't be performing a proper surgery. With the ultrasound, we get rid of all of that, and not only this, we excise less tissue and with lower amount of positive margins, which means less second surgery, that at the end of the day is less money, because we don't need to perform 2 surgeries on a woman that maybe with the ultrasound would have only need 1 surgery.